Welcome, everyone, and thank you for joining us this afternoon. My name is Whitney Meidel, Executive Director at the American Heart Association Puget Sound. It's my pleasure to welcome guests from across Washington to today's community conversation about maternal heart health, hypertension management, and prioritizing joy in patient interaction. The American Heart Association and Cambia Health Foundation, the corporate foundation funded in part by Regions Health Plans, serving members throughout the Northwest, Utah, and Idaho, have joined forces with the goal to improve overall heart and physical health for women and families in our communities. We're so excited to have you join us. And before we start, just a note for our audience, today's discussion is in webinar format, but we want it to be interactive. So even though we can't see you, we want to hear from you throughout the discussion. Please put your questions or your comments in the chat box and make sure to choose everyone from the drop-down menu. Now it's my pleasure to introduce our moderator for today's discussion. Lexi Price is an Associate Program Officer with Cambia Health Foundation, supporting the resilient children and families and healthcare workforce focus areas. She received her master's in public health through the Department of Global Health at the University of Washington. Lexi previously worked with the Global Center for Integrated Health of Women, Adolescents, and Children, researching adolescent HIV in Kenya, and subsequently worked as a graduate teaching fellow for topics in public health, including social drivers of health in the U.S., global violence and health, and global mental health. In addition to managing a portfolio of grantees for Cambia Health Foundation, she leads collaborative work with partners across the Pacific Northwest around birth equity. Welcome, Lexi.
Thank you, Whitney. I'm really honored to be here today to facilitate this important discussion. If there was ever a time to mobilize around maternal health, it's now. And as we will learn today, utilizing joy can play a key role in how we create optimal outcomes for patients and providers. I'd like to introduce to you our speakers for today's discussion. First, we have Nicole St. Clair. She has been leading Regents Blue Shield's clinical strategy in Washington as Executive Medical Director since 2022, focusing on improving health outcomes, reducing healthcare costs, and building meaningful partnerships with community and healthcare organizations. Prior to transitioning out of direct patient care, she maintained a successful women's health practice in Seattle, earning recognition as 2014's Outstanding Specialist of the Year from Kaiser Family Medicine Residency Program and Top Doc designation by Seattle Metropolitan Magazine in 2015. As a lifelong Seattleite with deep roots in the Puget Sound community, Nicole is dedicated to enhancing the health and well-being of her neighbors and fellow Washingtonians. She actively contributes to this mission through her board involvement with local and state organizations, including CFAIR, the BRIE Collaborative, Washington Vaccine Association, and American Heart Association. Outside of her professional pursuits, Nicole values time with loved ones, exploring new interests, traveling, and enjoying music and cooking. Welcome, Dr. St. Clair.
Thank you.
And next, I'd like to introduce you to Dr. Rachel Chapman. Dr. Chapman is a medical and activist anthropologist and professor of anthropology and adjunct in global health and gender, women, and sexuality studies at the University of Washington. Her work addresses intersection of race, class, gender, and politics of health justice in the US and Mozambique. For 32 years, she has illuminated cultural change and continuity, youth resilience, and peacemaking, power and performance in oppressed communities, especially movements to end health disparities. Her expertise includes critical race and Black feminist history and theory, global health disparities and austerity policies, culturally congruent health seeking and service delivery, HIV treatment and pregnancy, decolonial concepts, and community action research methods. From Dr. Chapman.
Thank you so much. It's great to be here.
To help us transition into our conversation, We wanted to provide each of the panelists an opportunity to give a little bit of a summary of the context and definitions for their perspectives that they will be sharing today. Dr. Sinclair, would you kick us off, please?
Sure. Thank you so much. It's really a pleasure to be here today and have the opportunity to raise awareness around maternal health and the work that we need to do to help our moms be healthier and promote healthy moms and healthy futures. If you've really had a chance to listen to or read anything about the state of maternal health these days in the US, you know that it's really not very great, right? When you compare our maternal health outcomes in the US to other similar well-resourced nations, our moms here have severe complications or actually die at a rate that can be as much as 10 times higher than other similar nations. And looking at how this happens as we start to break apart, what's causing that, we do actually see that cardiovascular disease and in particular hypertension are at the root of over a quarter of those US deaths. So very, very impactful. I want to talk a little bit about some of these statistics just to kind of set the stage for why this is so important. Excuse me. And I would call out that these stats are for all women in the US. But when we look at individual subsets and cohorts, we actually see that Black and Indigenous women suffer complications and death related to maternal problems, maternal complications, at a rate of 2 to 3 times higher than white women in the US. So problems abound for all women, but are also being felt disproportionately. But even worse, the CDC has identified that at least 80% of these deaths are actually preventable. So clearly, there's a huge body of work that we kind of need to dig into and address. When we look over the last 20 years, we have not seen things improving. We've seen the rates of women entering pregnancy with cardiovascular disease, or more in particular, high blood pressure. That has increased by about 67% over the last 20 years. But again, when we look just at the subset of Black women, we see that that's actually increased 87%. And that's in the setting, in the background of knowing that if you come into pregnancy with high blood pressure, your likelihood of having a fatal complication has actually increased by 130% over the same time frame. So really all of that is to say, moms are needing help right now in terms of achieving their best health outcomes. We know there are several factors that are impacting, but when we think about what are the medical diagnoses and the medical complications that are drivers, we really see a lot around hypertension and cardiovascular disease. One of the other things that I really want to emphasize today as we go through are the timing of when this happens. So we know that complications occur all throughout pregnancy, but interestingly, half of maternal deaths actually happen after the delivery. And a majority of those are actually a week or more after delivery. So once you've gone home, theoretically, and are having a little bit less monitoring and a few less touch points with the health system, that's where we can see some of these health conditions arising. And as we look, there's been quite a body of work that we'll talk about in our discussion today around, well, if we know these facts and we know that this is happening and we know these are the groups impacted, why have we not been able to make improvements? And even worse, why have we seen outcomes worsening consistently for 20 years? So I think that's really what I want to emphasize, just to set the stage of how important this is, and then really look forward to unpacking what we all can do as a community to recognize this issue and change this tide. Thank you.
Thank you so much, Dr. Sinclair. And Dr. Chapman, would you please provide some information with the audience about what you plan to share today?
Yes, I really feel honored to follow Nicole, who gave such a great foundation. It reminds me, last summer I was in residency at the University of Oslo in Norway, and they in 2023, compared to the United States, had zero maternal mortalities, which emphasizes this can be prevented, and people do. So let's just start with that all of this, there's the possibility of changing it. And there are three concepts I've been working in Seattle over the last 8 years with the most underserved communities to try to figure out where along the perinatal care journey, from before pregnancy to pregnancy, through birth, and then postpartum for years after, where's the best place? Where are people falling through the cracks? Because one of the things that we're really trying to emphasize is shifting away from saying these are pathological people, communities, and bodies to these are people who fall through the cracks of systems, or when they do enter systems, don't access care that they need or that's right for them, or that honors or dignifies them. So there's three concepts that I hope we'll get to talk about. One is the good Black birth, and I just like saying those words, good Black birth, to sort of resist the pathologizing that happens so constantly. And this refers to the paradox that happened during COVID. Everyone who was monitoring the kinds of negative health outcomes that could happen during birth, during COVID, there was a weird paradox. Um, in some cases, maternal mortality went up and negative infant outcomes, and in some cases it went down. And for those of you that were delivering care during that time, you know that it was a really difficult time. People didn't know how to address birthing during COVID. But for some people, that meant being excluded from care. You didn't get access to care. And in very few cases, people got to birth, especially Black people got to birth at home. And we saw people talking about this beautiful, safe, protected Black birth, maybe even protected from health services. So I want to just think about what are all the things that would constitute a good Black birth. So that's one thing we were talking about. The second thing was authoritative knowledge. Dr. St. Clair talked about touch points. During COVID, people had few to no touch points except telehealth. And we wanted to work with communities to make sure that the people who were most likely to suffer from hypertensive disease during pregnancy, preeclampsia or eclampsia, had access to the basics, which was a blood pressure cuff and how to use it, the information of how to use it. And what we found after the last 4 years of watching, listening, talking to people about just having it, even if their insurance didn't cover it, making sure everyone had in their hands a blood pressure cuff, people started saying, I feel confident. I feel secure. I know what my body feels like when it's good. I know when I have a problem, and I feel confident to self-advocate and to self-care, which meant reaching out. Our hypothesis was that there would be more touch points and that more touch points would save lives. And the last is where we've come from over the last 20 years, all in really good faith, from cultural competence to cultural humility to cultural congruence, going from sort of checking a list of what makes people that are culturally different from me hard to deal with in care to how do I meet as a full person with joy and hope and dignity and uplift? How do I meet that person sitting across from me as a whole person and them as a whole person, where we seamlessly put together wraparound care together as a joint project? And yeah, centering joy in that. So those are the three kinds of concepts that have been giving me hope in a time when we are watching the odds of having negative outcomes really rise based on institutional changes and the loss of funds and services.
Thank you both so much for all of that context. And I don't know about the audience, but I'm really looking forward to jumping in and learning more. So let's get started with some of our questions. Dr. Sinclair, can you elaborate on how hypertensive disorders in pregnancy can emerge during the postpartum period? And what is research revealing about the timing and causes of maternal deaths related to cardiovascular disease?
Yeah, that's a great question. And I really want to emphasize this postpartum time period is really important. Again, we sometimes can falsely think that, the main actions happening during the pregnancy, you deliver and you go off and everything's fine. Many people, for all kinds of reasons, know that not to be true. And when we look at complications or thinking about blood pressure, we know that about 25% of people who develop a pregnancy-induced blood pressure problem, that may not actually show up until postpartum. And so there are physiologic changes that happen in pregnancy that take weeks to unwind. And we also see, as women are kind of in that postpartum time period, those changes and that physiology is still happening. So again, some women can actually newly develop high blood pressure just in the postpartum time period. But even thinking about the people that we already know who are at risk, those who either came into pregnancy with high blood pressure and it stayed the same or worsened, or those who came in with normal blood pressure but developed a pregnancy-related hypertensive condition, that blood pressure doesn't just normalize right away after you deliver. And that's universal across all groups, even those high risk, low risk across the board. Dr. Chapman had mentioned some international studies. It was interesting. There was a study that was performed in the Netherlands, which has an incredibly persistently low maternal death rate. I mean, we're talking maybe one, per 100,000, if even. Within that cohort, though, they did take a look at women who developed severe high blood pressure during their pregnancy and found that about 39% of them continued to have severe high blood pressure postpartum. And actually, for half of them, it took 2 years for that blood pressure to normalize. And we also know that if you've had high blood pressure in pregnancy, your lifetime risk of cardiovascular disease actually increases by 75%. So during this postpartum time period where we see complications happening, again, a large number of maternal deaths, there needs to be closer monitoring and awareness, both for the individual to know that she's still at risk and needs to be in the awareness, and of the circle of caregivers being aware of what's happening, but also just recognizing that the pregnancy episode continues for 6 to 12 months after that delivery. That's the way we think about it health-wise, medically speaking.
Thank you so much, Dr. Sinclair. Dr. Chapman, what are the biggest challenges to addressing maternal health equity and eliminating persistent racial health disparities like maternal hypertensive disorders, especially for Black women?
Well, you might want to say first and foremost that a hypertensive disease, besides measuring the stress and your access to healthy lifeways in your community, that has not changed for hundreds of years. The difference between what it means to live as a Black person, especially as a Black woman in a Black body, it hasn't changed. And we're still looking at the ways in which institutions quite frequently still expect us not to experience pain in the same way, not to be able to metabolize stress in the same way. So one of the main things that we need is universal access to great care. And that's going to look differently across communities. We still are in job and economic and social situations where we might not have access to the best care. And when we get care, we might actually be treated in ways that actually continue the stress, the depression, the worriedness, the hyper vigilance that we're not going to be okay. So the distrust of systems. So one of the things that I have the honor to be working with the American Heart Association and with Emily Reynolds, who's here, is what does it look like to work with birth workers from the very community where you live, that know your language, that know your culture, that know your rhythm, that know your ancestral histories, and to work with those people to see if there's a way to bridge these gaps. The other gap that Dr. St. Clair brought up that's really important is that we tend to treat pregnant people as one group of people, infants and children as a separate group of people, and then sort of postpartum people get lost in the mix. And living in Washington State, it's really thanks to birth workers like midwives and doulas that fought for there to be care so that you're actually covered by Medicaid to be able to access care that watches you in that next period. We could add to the information that Dr. St. Clair gave us about postpartum deaths. In fact, a lot of those have to do with addiction. They have to do with mental health needs that are unmet. And that tells you something about the stress of living as a new parent, as a growing family in this country, in this moment. And that but by the time you've gone through 6 weeks and you've had your last appointment with your infant, who's watching for you? Who's paying attention to you? And do you have everything you need to be able to manage the stress, the pressure, of that transitional moment. So all of these things are really important, and I'd love to hear from our audience who has direct experience with this. But I do think that the most well-meaning of care providers find themselves having to have so many visits a day just to keep their practices viable that they don't necessarily even have the time to notice, how are you doing? What brought you joy today? What's stressing you out? What else in your life might need balancing and support for you to be able to be in this difficult physical, mental, psychic transitional moment, and social for families? So all of those things mitigate in some ways against changing these dynamics.
Thank you. Go
You
ahead,
know,
Dr.
I just
Smith.
want to piggyback on that. As we talk about stress, it's oftentimes really kind of hard to measure or quantify, even though we know kind of existentially that stress plays a role, and especially when we're talking about blood pressure and kind of the types of interactions that you're having. And we've seen this actually even in some kind of initial small studies, even in the Journal of the Heart Association. There was a study out of New York that looked at women's perceived experience of kind of gendered racial microaggressions and how that impacted their blood pressure. And they found that those who felt that they were experiencing microaggressions had higher blood pressure 3 months postpartum. When we also look at complications and disparities postpartum, we see that there's always disparities of complications, across the spectrum. But when you go from just the delivery to the postpartum time period, those disparities actually increase. So we are losing people in this postpartum time period. As you said, they're not getting those touch points, they're not getting that support, and they're having a disproportionate amount of stress during that time.
Thank you both so much. I, I'm hearing that there's this gap after birth, and the support for birthing people. I'm curious how doulas can be effectively integrated into, clinical blood pressure management systems to support those outcomes and other ones as well. Really, really extending that care team.
You know, there's been so much around doulas and how doulas can help in so many different ways. And I would emphasize just what you said in terms of being a part of that blood pressure kind of just monitoring and surveillance team. The clinical team in the office, you have kind of limited touch points with them, and they're really relying on this, the hope that there's an external system where you're getting the support you need, you have the equipment you need, you're checking your blood pressure, you're understanding what those readings mean, and you have someone that is helping you with that, helping you contact the office. Sometimes you call the provider's office and no one answers, or you leave a message and no one gets back to you. What do you do in that moment? Having another knowledgeable professional, such as a doula, can really help someone both troubleshoot when they know there's something amiss and they're not sure how to address it, or just even recognize, hey, there's something going on here that we need to be more persistent, or we need to kind of pursue in a greater way.
It's probably important to mention that lots of women of color are not as familiar with doulas because they have been a type of care that not traditionally, that's probably when people say, what was the first occupation? The first occupation that anyone ever had was probably doula. That is holding your sister's back, making sure she has water when she's in birth. Like that's probably the first job anyone had. And it was a job of love. But it's rather new, and Washington State actually is the doula capital of the country. We have more doulas per capita. And it's doulas of color who have argued for and changed policies to get this covered by Medicaid so that more people can afford it. And they are at the heart of developing programs, services, innovations across the state that have been life-saving and life-changing. I know that University of Washington has just started the Black Doula Collective, which is hoping to serve lots of folks. And I know that Swedish has just recently published that they have reduced C-sections in their vulnerable communities by having culturally congruent doulas at their sides. So who the doula is someone that watches from the very beginning. ideally from the very beginning and holds the memory of the birth for that parent all the way through. And now there are more postpartum doulas, but a doula is watching the whole rhythm of things, and yet they have the least power. In all of these programs across the country, from Chicago to Detroit, there are cities that are saying we have to stop these inequities and figure out the best way to do that. The person with the least power has the most knowledge that can be shared, and is more likely to be able to be an advocate and hold that birthing person from before birth, through birth, all the way postpartum. So we have examples of that here from Open Arms, that's been serving people for such a long time. Rainier Valley. We have, I want to talk about Fiza, who's one of the first women of color to open a birthing center in Federal Way, and for global midwives that she works with. It's doulas of color that are seeing, how do you change the rhythm of care and stay with people, so that they don't fall through the cracks, and so that they have this advocacy and this authoritative knowledge, which means being able to speak for yourself on your own terms about your own experience as the expert of your body, your birth, and your health.
Isn't that fascinating? I just kind of want to double click for a minute on the success that we've seen just even in our local community with some of these programs. And the Seattle Times just published the article about the success that Swedish Hospital has experienced here in Seattle. I know myself and many colleagues, at one time or another in our careers have delivered at a Swedish, it's a large volume, community hospital. And through their doula program, they were able to close a disparity in C-section rates. But I found it remarkable that they had a C-section rate among first-time low-risk Black moms of 44.7%, super high, and that in a very short time period, just a couple years, it dropped all the way down to 27%. I mean, that's remarkable, in all of the ways. And so when you think about that, it just really points to a medical indication doesn't change, right? A medical problem, the need for a C-section kind of urgently, emergently for a variety of different reasons shouldn't change. So it's really powerful to see that we are believing that all of our C-sections have these proper indications, but clearly there's some room to trim, that they were able to see that much of a decrease in that rate.
Thank you so much. Talking about this reduction of C-sections and looking at, not only reducing these aspects of birthing, what Dr. Chapman specifically, what does a good Black birth look like? What does it look like for folks giving birth, but also for the providers involved?
Well, thank you for asking about that, because it's the thing that wakes me up with a smile on my face, to be in pursuit of it for everyone. Like, everybody deserves a good Black birth. And this data comes from the last 4 years in a project called Heart and Soul, and then Heart, Soul, and Joy, which was delivering blood pressure cuffs and home screening tools for blood pressure, stress and depression, household security, and relationship safety, because we felt like a lot of people don't talk about those last three things openly with their provider, even though it's affecting their health and even their heart health. But we thought if we put them together, like, it should be as 1, 2, 3 as checking your blood pressure, to say, how's my relationship? How is my home security? How is my stress right now? So after talking to hundreds of women and listening to what their experience was, many of these during COVID, we came up with 5 things that so far begin to help us define a Black birth. And I'm going to read them to make sure I get them right. And just so you know, this is from a team of many providers, many community activists, many folks at UW, faculty, staff, graduate students, and undergrads. And we've been working on this. First and foremost, it centers Black authoritative knowledge, which means centering the Black birth worker, parental, familial, ancestral, and embodied somatic knowledge to direct the birth setting, birth decisions, and the flow, like when to push, when to rest, when to eat. Second, it fosters Black family support, peace, dignity, and community traditions. Third, it safeguards Black birthing persons, families, and communities' sense of agency, autonomy, self-efficacy to enact life-giving and life-saving um, care on their own behalf and on that of others. Very importantly, it should mitigate, resist, and undo racialized harm and trauma. And last, it promotes healing and joy in Black play, sexuality, pregnancy, Black birthing, and Black futures. And I think all of those things could be extended to any birth and the cultural importance, voice, knowledge, and support that that means for anyone that comes from their community and history. So that's a good birth. And that was sort of the opposite of what was happening for many people during COVID who were alone, not allowed to have any support. People were treating them as a disease themselves because they weren't sure how COVID was affecting people's bodies during pregnancy. So that's a good Black birth.
Thank you, Dr. Chapman. For this next question, I'd like to encourage the audience to add their thoughts to the chat. So please feel free as you're listening or reflecting, please participate in the chat and we can also continue this discussion, make it a little more interactive. Starting with Dr. Chapman, what barriers in traditional medical settings and models prevent culturally congruent and joyful care? And I think before we go into that, can you expand a little bit more on what culturally congruent care is?
Yes, really quickly, I think people understand what that cultural competence really came up from people realizing I give care in a universal hospital. I'm seeing 8 people from 80 languages and cultures. And it was the goodwill of people to say, I need to know more about the people I see, to be able to meet them where they're at and to not make mistakes from their religion to their gender preferences to their way of eating or even taking or accepting medicine. That kind of started to be a little bit rote, like lists. Cultural humility was developed by Black care providers, Black and Brown care providers in the 1980s who said, actually, we need to constantly think about how can we as providers change ourselves and keep learning and keep being humble in the face of perhaps histories and cultural ways and cultural importance that we can't know that is housed in our patients and in our patients' communities. Most recently, congruent, even though the term was used in the 1960s by people who were talking about cultural humility and cultural competence, it now means engaging as two people with culture and power. Yes, and addressing, looking at your own bias and thinking about how am I entering this room also with power. There's just not one cultured person here. We're both cultured, and my culture may also have responsibility for either succeeding or failing in being able to bring care to this person. So those are the differences that I think are important in this concept for the moment. I hope that helps, Lexi. And please add, Dr. Nicole.
Yeah, no, I love that. And I mean, I think you hit it right on. There used to be kind of an emphasis in understanding, as you said, and thinking about how you can maybe avoid missteps, but it goes so much further beyond just understanding. It's really truly understanding the importance and the significance of what people are bringing to you. I think we see this sometimes as OBs with a care plan and understand and having that discussion and really knowing like what are the things that are truly the most important to you in this experience. And then from the provider side, thinking about how can I truly integrate this? So as you said, that we're really going hand in hand as opposed to I've read this manual, I understand what's important to you and people like you, and I'll kind of keep that in the back of my mind as I move forward with my plan. It's much more of a partnership.
The chat is really filling up with so much good observation from people that are on the front lines of this, from implicit and explicit bias. For those of you who are interested in learning more about this, one of my favorite scholars right now, her name is Shona Hunter, and she actually looks at the relational choreography of caring labor. And she says, even when you're well-meaning, how is it that people with more power, whether that's historical, racial, gender power, how do people recreate domination and control of people even when they are not intending that? What is that choreography? That fascinates me. And that really means some unpacking by people to think, how is it that I could be thinking I'm doing one thing and then doing the choreography of another thing? And that's where the work that we've been doing to slow people down and to say, this is a whole person who actually is not a risk, who's not just risk, um, they're also someone who has a right to joy every day in small and big ways. And that's been a time something that we've seen providers kind of saying, whoa, you don't know how much that's my intention and how much the timing of my encounters has made that really hard to do. But it's really we're thinking that it's as important as any other virus, that pathologizing someone is a pathogen, and seeing their dignity and joy is actually the beginning of healing.
Well, and I would just piggyback on that and tie that back into we see that at least 80% of maternal deaths are avoidable. And, so kind of where is this disconnect, right? As you were saying, everyone's kind of doing their best to achieve this best outcome. And I think it kind of comes into the nuance of communication, the fact that there isn't always enough time. Maybe we're speaking the same language, but we're not speaking the same language, using different terms, terminologies, and references. And that is where that doula and support person can be the translator to help with the communication that's needed. When we look at these maternal deaths, oftentimes and specific to cardiovascular disease, we see a lot of them are due to delayed or misdiagnosis. And when you kind of peel that back, we find that a majority of that delayed and misdiagnosis has to do with poor communication, miscommunication. The CDC has called this out, and they have a whole campaign called Hear Her, which is really just emphasizing that, especially in the world of kind of hypertensive disorders of pregnancy, a lot of times that pregnant person is the one who really is most in tune with what's going on and can truly feel the changes that are happening. And with hypertensive disorders, identifying early and acting early are super important to preventing complications. We've seen this on the CDC. They have individual testimonials of, just regular people of society who we don't know, but also celebrities like Allison Felix and Serena Williams. And when you hear their stories of how these folks are highly resourced, very prominent, yet still experienced either a potential or a real medical poor outcome or complication as a result of a delayed or misdiagnosis, it's really remarkable. So it kind of comes back to what is this other person, this doula, a person who's not technically part of the medical provider team, how are they able to reduce C-section rates? How are they able to actually impact, medical health outcomes? And again, it comes to bridging that gap and helping that care team identify how they can operate perhaps in a more culturally congruent way to see and hear what might be otherwise being missed in this person's health journey that is ultimately going to lead them to a bad outcome that we can stop it, in the works.
Thank you. On that, Samantha mentioned in the chat, kind of thinking about, yes, this network of care with providers, the doula, nurses, and MAs, but also thinking about folks that are at reception and beginning that experience very early on. And I think that's such a great point to think about how folks are centering care with not only the patient, but between all of these different folks that are playing a part in this birth. So that's such a
Mm,
great point, Samantha.
that's a really beautiful point. I was recently at a grand rounds at University of Washington where Mama Shafia, who's one of the longest standing Black trainers of doulas, who's in Portland, I believe. And she started by giving a whole history of the role of Black women in reproduction in the United States, starting with the use of enslaved women for experimentation around obstetric surgeries. And at the end of it, I was like, you cannot talk about this without talking about history. And when you walk into any room, regardless of who you are bringing 400, 500 years of history into that room. And one of them is not listening um, to Black women. And that's such an important idea that Samantha has, that where does that start so that you feel heard, you are have the courage to raise your voice when things are not going well, and you have the courage to insist when you haven't been heard. And maybe this idea of asking providers to let the least powerful person in the room, who's a doula, to suspect that they might be the amplifying voice of what's going on for a birthing parent, a family, a community, and that those voices working together should be paid attention to. It's really powerful to me to think I need two people at least in the room speaking on my behalf so I could be heard. But I think that's a change in providers. And provide being a health provider is a culture. It doesn't really matter what your background is. You've been trained into a culture of thinking where power should be, who should make decisions, how things should go. And I think projects like the Black Doula Collective is trying to turn that on its head and said, there's someone in the room who you don't think has power, who needs to be seen as powerful and important to help this birth flow in the way that it should, and that ultimately that's better outcomes for everyone.
You make such a great point in calling out that as providers, we need to be thoughtful about how to recognizing that that doula is perhaps an amplifying voice, right? That, someone that an individual is having a touch point, or maybe if you don't have a doula, maybe it's the support person. And especially, as you called out in the beginning, sometimes someone who doesn't necessarily identify the doula by name may have picked a friend, a relative, a sister, someone who they feel confident in, and that person oftentimes shows up at the visit saying, I'm here to advocate on my loved one's behalf. Because I think we all have felt a little bit of we all have felt the dynamic when we're receiving care of wanting to be somewhat respectful, or I don't want to say deferential, but you're kind of giving the benefit of the doubt to this caregiver, and you may be more inclined to second guess yourself where you wouldn't in a different setting or situation. And I think us even recognizing that tendency and acknowledging that trusted person who's there in the room, like, hey, is there anything you would add? Were there, anything that you want to chime in? Um, I have, I know lots of people who oftentimes are very vocal in themselves, but in that setting, in the medical setting, they are more comfortable sometimes having someone else be that intermediary to try to help, the perception of that relationship still staying smooth with the provider. So it is a choreography, as you've said, and everyone kind of has steps in the dance to help make it easier for us all to flow.
What do you all think about, and I'm sure the audience will jump in, what do you all think about having this discussion at a moment when probably one of the biggest dangers for birthing folks, especially that already didn't have very good access, the closing of labor and delivery wards and maternal health programs around the state might be the biggest kind of danger to folks, that there just aren't, there's going to be even less access.
It's I definitely am curious to hear also from the chat. I know that's something that we think about at Regents in looking across our populations and seeing the areas where you do start to see maternity deserts popping up, and knowing that those are bad for everyone, but they also disproportionately impact those who have the least resources in those communities.
I should uplift one of the things that are in the American Heart Association project that Emily Reynolds is heading up, to make sure people have access to blood pressure cuffs and know how to use them. A very key part of that is that you and the people around you know the emergency signs of preeclampsia and eclampsia. So that every person, like, I feel like every person should know what it looks like for a woman to have a heart attack, because it doesn't necessarily look like a man.
Mhm.
Everyone should know what it looks like to need care in pregnancy when suddenly your heart rate is spiking and all these other things that you can actually know, from swelling to dizziness to the way your eyesight is changing. And that's a really important thing, so that people don't wait until absolute crisis before seeking care, especially as care gets further and further away. So I think that's a really great small piece of this project, is making information available to everybody, like an automatic thing. Let's tick them off. Teaching your little 2-year-old to sing this song.
Thank you so much. With the few minutes that we have left, I think everyone's really interested in hearing about some of these practical steps that folks can take into their work, even despite the uncertainty um, that we're all facing right now. How can folks bring joy into their work and work against these traditional systems that are keeping outcomes poor?
Are we opening this one up to the chat as well for
We
people to?
can, and please comment in the chat if you have thoughts on that as well.
Yeah, I think there's plenty of room for lots of ideas because there are so many different places and touch points in the process where there's opportunity, kind of as even it was called out in the chat with just the structure of the checking in, like your first touch points with kind of the medical system. Are you already feeling a little bit on edge, a little bit anxious? Are you already kind of associating this experience with, as you said, kind of a negative, you know, medical moment? But then also too, I mean, I come back to, I think what we just have to really center around, these deaths and these bad outcomes are preventable. And let's take a look at the successes that we've seen and what we can learn from them. As we've talked about with not only Swedish, but in other places where we've seen an intervention that really prioritizes communication, more shared decision making, cultural congruence, some of these key factors that we know are important, but truly have put them together and seen a positive outcome. So it goes from being theory and speculation to they've done it. Let's look and understand more how they've done it and how we all can recreate it, what components can fit in our own systems. So I think we have to start moving from kind of what we like to, joke as observing the problem into really taking some tangible steps, or even just trying a few things, saying, okay, we've identified this area, we've gotten this feedback on our, from the provider side, we've gotten this feedback on our patient satisfaction scores, and we see that this is an area that, some of our subsets of our women, our patients are not having the good experience that others are, and really just turning that into action and responding again with the same um, uh, kind of pressure that we should feel when we look at a number of 80% or more of deaths being avoidable. And I mean, I want to put a number to this. There were over 6,000 women who died. I believe this stat is from I want to say it's from 2016, but I mean, 6,200 actual people. So this is really just incredibly important.
That's a kind of a powerful statistic to sit with. Thank you. I hope that this doesn't sound trite, but to the extent that how you see people is how you treat them, and how people are seen and treated has implications for their outcomes. If you seeing me as a pathology, as a risk constantly, rather than someone that has joy, if you imagine that has the capacity to make me sick, you might invest in your own joy practice. So that you begin every every time you sit down to say, breathing in, I'm full of life. Breathing out, I belong here. And starting before people say, so how's that blood pressure? How did you get here today? What brought you joy on the way? Did something bring you a moment of joy, a taste, a sound, a touch? So many people say, oh, my kiddo's smile. the cool weather on my way walking. And that changes everything. We had in our cohort of in the first project, about 120 people, one of the women said, I thought I was going to die every day for 40 weeks. That is something that's being reinforced in healthcare. Yes, it's in the headlines. Yes, you're reading about Serena Williams. Yes, but that's being reinforced. If you could imagine that pathologizing, our team actually, and we were a team of about at the height 20 researchers, 12 of whom were Black women. We started feeling sick. We were all kind of like, oh my God. And it's because every day we were thinking about the risk of domestic violence, death, depression, stress, and preeclampsia and eclampsia. And we said, we have to change the way we do research, the way we work with each other, the way we work with our research participants and with the providers. And we started centering joy. So we would begin opening every meeting, every conversation, every interview, um, every survey with joy. It made such a difference. Um, so I think that's really important. We also, someone is putting in making pregnancy and postpartum teams with a workflow and action checklist, something that people mentioned often that is not in workflow. Please tell me if I'm wrong. Is this post-placental moment, like you've given birth, you may or may not have delivered the placenta, but it was a time between all your family running in, all the healthcare coming and helping you to deal with baby, and then all of a sudden you're alone and you're in deep pain and you're exhausted, but you're not really sure what's happening. So many people said they wish that either they could have visitors at that time, their doula or midwife with them, or that providers would come and check on them. It is not like a happy, silent, it's a moment where people are often in fear, in pain, and alone. And I would love if we called it something like the post-placental moment, but making sure that there's a time when people are visited right after that, and that time when you're alone and visiting hours are over. I feel like that might be a really important thing for whoever put making a checklist. Samantha
Yeah.
and Julie had a question. How do you feel about team birth program to involve everyone in the room to keep them all involved, aware? It worked well to reduce C-sections. I worked at a hospital in Seattle that closed, and it was so sad. Used to work with wonderful doulas. That sounds like a crucial program. I wish we could hear more from you. But if people are looking at the chat, team birth.
Yeah, there's some great questions in the chat. Um, we do have to start wrapping up, unfortunately. Um, I love this conversation, and I love the idea that in order to improve outcomes, we need to look more inward and into our patients rather than to those outcomes themselves, right? In order to improve them. I love that. So thank you both so much for your time today. And is there anything else that either of you would like to add in before we wrap up today?
I just want to say thank you to everyone who, took their lunchtime to listen and participate on this issue. And I would just leave to Rachel. I love leading that idea of leading with joy of, starting every encounter with, let's think of something good that happened or something good that's happening before we get into some of this heavier stuff. So I love that.
There's some beautiful thanks coming in. I also want to thank um, all the folks at Cambia and American Heart Association and Lexi for being our facilitator and asking such great questions. Thank you so much. This was a huge honor. I can't think of anything more powerful and important to be thinking and talking about at this moment in our state. And we're lucky to be in a state where people want to have these conversations and might actually come up with the right things to do.
Yes, thank you both so much. I can't tell you how many times I had chills during this conversation. It was wonderful. And we hope the audience leaves this conversation feeling inspired with new ideas and perspectives to take with you as you interact with the people that you care for and the care teams that you work within. And I think also within yourself, taking care of your own heart and self to bring your best work forward. Um, and thank you, Cambia Health Foundation, for sponsoring today's event. A recording of this webinar will be emailed to all registrants. And after you exit out of the Zoom room, you will see a pop-up to take a short survey, and we appreciate it if you'd complete the short 1-minute survey to provide feedback and ideas about future conversations, because we want to cover topics that you're interested in that will make the most impact. Thank you, everyone, and have a great day and take care.
Thank you.
Thank you.